Good afternoon. This is Robin Jones, Stroke Program Manager for Mission Health, and I have with me today Kelly Pace, one of our emergency department nurses from Mission, and Dr. Reed Taylor joining us via telehealth from Mission Hospital. What we're going to do right now is go over a typical scenario with telestroke, and so I want to walk through a few teaching points, and then we're going to go into a scenario in which I will be the family member of the patient, Kelly will be the emergency department nurse, and Dr. Taylor will join us via telehealth. A few things to remember when you activate a code stroke telestroke. You're going to CT scan, you know you're working a code stroke, you simultaneously activate the telestroke provider by calling Mission Direct, talking to the supervisor there, telling them what you have. He or she will then have the time to get on the laptop to beam into the device here to see the patient. When you're bringing the patient back to the room, you want to make sure that you have the device in the room. You don't want to have to be going down the hall and finding it behind a cart. You want to have it in the room. You want to go ahead and have your TPA clot box available and handy, and you always want to have a staff member, an RN and or the physician provider in the room when the telestroke doctor joins the case. A couple of other caveats is that our new cart system here, the provider is not able to drive the cart. He can actually maneuver the head, he can change the zoom on the lens, he can turn up and down the volume, but he's not able to drive the device, and so if he needs your assistance to move to the other side of the stretcher, to be able to get into a different angle towards the patient, it requires a staff member to be available for that. Plus, you want to know when the provider says, hey, it's a go, we're going to treat, then you're here ready to go ahead and mix the alteplase and begin the treatment. And now we'll go ahead and go into our scenario. Thank you, Kelly, for agreeing to be an actor in this, and thank you, Dr. Taylor, for joining us.
So I'm Dr. Taylor. I'm one of the stroke neurologists. I talked to the ER doctor, and they told me about something about what happened. Kelly, thank you for being in the room when I get here to help me examine this patient. They told me that these symptoms started about 1 o'clock, that the patient is a little weak on their left side. They had some trouble moving their left arm and getting the right words out. And that's about as much as I know. Is that the story that I'm hearing?
Yeah, we just had lunch, and I left her for a few minutes, and I came back and I found her. She had dropped the fork, and her speech is just kind of garbled. She can't make good sounds with her speech.
All right, thank you. Kelly's going to help me do a few things that are going to try to understand how much of a stroke we're having right here. So I'm going to ask her some questions. How old are you?
She says she's 82.
All right, and can you tell me what month it is?
She says it's March.
Okay, and now I would ask her to make a fist with her right hand. And she's doing that, and then I would say, okay, can you close your eyes very tightly for me? Okay, I can see you've done all those things. And now I'm going to have Kelly, I can zoom in with my robot and look very closely at this lady's eyes. I'm going to call her Miss Jones. And Kelly, I'd like you to move your hand back and forth in front of her face and have Miss Jones follow your finger. Now, you may not be able to see very well, but the way Kelly's doing it right now, she's got her arm perfectly in front of my line of sight. So the way she's changing it is a way to have the patient follow her finger, and yet she's not blocking my ability to see what's going on. So that's perfect. Thank you very much. And now we're going to check her visual fields. So Miss Jones, I'd like you to look right at Kelly, and she's going to, without getting in my way, have the patient count fingers to the side. So could you hold your hands out to the side?
Yep.
And test your visual fields?
She says 2.
All right. So you do that, and another way of doing it is to take both hands, hold it on either side of the patient's head from the back, and then wiggle one side or wiggle the other side, and have the patient point to the one that's moving. Exactly like that. Exactly like that. And surprisingly, she's able to correctly point out And so she did very well with that. And now we would say, Miss Jones, can you smile for me? Show me all your teeth. And at that time, we'd be looking for the patient's symmetry of smile, and we'd be running down the list an NI stroke scale that some people have right in front of them, or you're going down the checklist for that. And then the next thing you do is you'd start with arm strength, and you'd start on the good side. So you take that right arm and you lift that right arm up so that it's up at about a 45-degree angle. You let that go, and then I would start counting. 1001, 1002, 1003, 1004, 1005, 1006, 1007, 1008, 1009, 1010. That's the good side, so she held that up for 10 seconds. We'd let that right arm down. Then we take that left arm and hold it up in the air. So you take that left arm, hold it up, and say, hold this up, Miss Jones. 1001, 1002, 1003, 1004, 1005, 1006, 2007, 2008. So it looks like she dropped her arm all the way to the bed by the time I got to 8. So she's got a drift. And if you remember your NIH stroke scale score, that's a 2 on the scale. Now we're going to get her right leg, and I would ask Kelly to lift her right leg up about 6 inches. And we say, hold up your leg, and I would count 1001, 1002, 1003, 1004, 1005. She did well on that. We do the same thing with the left leg, lift it up about 6 inches. And I'm going to count 1001, 1002, 1003, 1004, 1005. And that left leg did not go down, so we'll say that was a 0 on that side. And the next thing we do is we get Miss Jones to make a pointer finger with her right hand, and then Kelly will put out a target with her pointer finger on her right hand, and Miss Jones is going to touch her nose, then touch your finger, touch your nose, touch your finger, do the same thing with the other hand, and we'd see if there's any ataxia with that. And the next thing would be heel to shin. So you take her right heel and run it down the left shin on the right leg, and the same thing with the left
Show it on your body.
heel down the right shin. Surprisingly, she's able to do that quite well. And then when it comes to sensation, what I usually ask for is a broken Q-tip. And you take a Q-tip and you break it so that it makes a little pointy thing. And then you just do a quick touch on the right side and a quick touch on the left side and say, is there a difference between those two sides? What did she say? Is there a difference on those two sides?
Yeah, she said this one felt a little different just then.
Yeah, so it feels different. So we're mentally adding up this score that she's having some deficit. And then the next thing, I would be sure to ask if Miss Jones wore glasses and she needs any help with her vision. If she does not, then I'm able to show these pictures right here that the patient is able to look at. She can either look at this, or if the patient we can't get the cart situated correctly so that she can see, then it's always helpful to have the cards right there. So Kelly would hold that up in front of the patient, and she would describe what was going on. So could you describe what's in this picture for me, Ms. Jones? I can't hear her very well, so someone might have to shout out what she's saying.
She's saying that she sees the kids are getting into the cookie jar, and the little boy's falling off the stool, and the mom's washing the dishes, and the sink is overflowing.
Okay, so she's doing very well with that. And then the next thing we do is ask her to name these items. And I'll just very, very quickly run through these.
Backside.
We would show her these things and say, can you name all what's on there? And the patient would be going over all that. And then we would ask her to read the following phrases. And so there's a list of phrases, and you ask her to read those. It sounds like she's reading these pretty well, but she's got a little slurred speech. I can hear her speech coming out slurred. And now I'm going to really test her, how clear her speech is by having her read these words for me. As we're doing all this, we'd be noting that there is a change in speech, either one that we could hear, or maybe her daughter at the bedside would say, this isn't usually the way she sounds. Is this her usual speech? It sounds a little slurred to my ear.
No, this is not. She's usually very easy to understand. This is not her normal speech.
Now, the last thing to look for is called neglect or extinction. And what I'll have you to do for me, Miss Jones, is close your eyes. I'm going to have Kelly touch you either on the left arm, the right arm, or both arms at the same time. And you say right, left, or both.
Left.
Yeah.
Well, that's her left. Right?
Yeah.
All right?
Right.
And so I wasn't getting exact. She feels it on the right, but she's not feeling it on the left. She doesn't have any simulation. So now we have to add up the score that we've got. She has a change in speech. She has a change in her sensation, which she does feel things somewhat on the left, correct? It's not completely gone. It's just, okay. So my score is that she's got a 4 on the NIH Stroke Scale score. And you know, she has a measurable neurologic deficit. I've heard that she does not have any contraindications to any thrombolytic therapy. What's her latest blood pressure?
Her blood pressure is 190 over 120.
I was just called to hear a report that her CT scan is does not show any hemorrhage, and she is a candidate for thrombolytic therapy, but before a patient can be treated, their blood pressure has to be less than 185 systolic. So the ER doctor, with the assistance of Kelly, would give an order for 20 milligrams of labetalol IV, and we'd give that. And while that was being given to the patient, I would recommend that somebody be drawing up TPA at the correct dosage for this patient's weight to treat her emergently for acute ischemic stroke.
I'll get my box.
Okay, so we gave her that. TPA is being mixed up. While that was happening, either the doctor here on the telestroke doctor, but also the ER doctor would be saying, now, Miss Jones, I know your daughter's sitting right here. These are stroke symptoms you're having, and that's why we got you to the emergency room. We scanned your brain and we don't see any sign of bleeding. We've got some medicine that is used to try to prevent a stroke when it's in the middle of its origin, when it first starts to happen. This medicine is not perfect. It doesn't always fix things, and it does have some risk. There's about a 2 to 3% chance of hemorrhage or bleeding, which would be a problem, but it does have a chance of reducing your stroke symptoms and increases the chance that you'll be able to get back to your usual self. And it's a time-limited therapy, so the sooner we give this medicine, the better. It has to be given within 3 hours, ideally, and the sooner we give it, the better. It's not like we feel happy to give it up to 3 hours. The sooner we give it to somebody, the better. And the team there in Rutherfordton has gotten the scan done, gotten the blood work. Her blood pressure is now down. If everybody is in agreement, I would recommend treating her with this blood clot dissolving medicine. Does the family and patient agree with that?
Yes, she says yes.
Okay.
Mm-hmm.
All right. It's not something that we would delay things by getting any sort of consent form signed. We would just document in our note that the patient had agreed and consented. And I would, at this point, have talked to the ER doctor, and I will also say, Ms. Jones, that we almost always transfer patients that get this medicine to the intensive care unit up here at Mission Hospital because we have the experience in looking at folks who've been treated this way. So part of agreeing to getting this treatment is agreed to be transferred to Mission Hospital. So I just want you to be aware of that.
Yep, absolutely.
If everybody agrees. Okay, if everybody agrees, I would probably sign off the computer and let y'all go ahead and take care of Miss Jones. Make sure that you are doing the usual blood pressure management, which is appropriate for her. If labetalol got her blood pressure down, it stayed down, that's fine. If she needed something long-term, then cardine is the thing to start. And I will call the bed supervisor here at the hospital and have them call you back with a bed assignment just as soon as we can get one.
So I think, Dr. Taylor has summarized very well for us the interaction of a telehealth provider coming in and joining your team in the treatment of acute ischemic stroke. A couple of things to sort of wrap up this section of our training is that you notice that he came in, he was able to do the full examination, but with the assistance of a nurse. So I want to reiterate again that we have to have someone in the room to assist with that evaluation. Secondly, there is also a handset on this cart, and I just want to check it really quick, Dr. Taylor, to see if it actually connects with where you are. Can you hear me now? Dr. Taylor?
Let me see if I can fix it.
Yes, I can. So the handset can be used if the telestroke provider wants to speak directly to the family or with the ED physician. There can be consultation even while the telestroke doctor is still in the room, and that might actually help. That may help facilitate some of the transport decisions and conversations. Again, if Dr. Taylor mentioned that he was able to get a report of the CT scan, but he may actually have to leave the room in order to go see an image from PACS, and so there may be opportunities for us to improve that turnaround. But this particular cart does not drive itself, and so you got to have assistance to, if he needs to go out to the main desk and take a look at images, he'll need someone to escort him to do that. And lastly, I just wanted to thank Dr. Taylor for joining us, but I wanted to know if you could just speak for just a minute. We went through a scenario of a woman who's treated with IV thrombolytics and would be transported to the intensive care unit at Mission, which typically could be by ground. But if you could talk just a minute to the scenario in which one of our telestroke providers may wish that the patient is either flown by air medical and or you're wanting to transport directly to neurointerventional radiology, what additional help you might need from the staff at Rutherford Hospital.
Occasionally, if you get a patient who comes in and you see that their stroke symptoms are profound and their imaging study shows what looks like it might be a clot in the middle cerebral artery, which is the one that you'd be able to see most easily, you might say this is a candidate for endovascular therapy. And endovascular therapy, simply put, is when you bring the patient to the x-ray department, do an arteriogram, and use a device that pulls that clot out of there. And it is can be done after the patient's treated with IV therapy. Generally speaking, we want to get the patient here in a hurry. We do not want the person to be moving around a lot, so we often are arranging intubation perhaps beforehand or as soon as the patient arrives. So we'd probably be negotiating with the ER staff there, talking to the transport people about how we would most easily get that done. So the idea of treating somebody with IV TPA, I cannot emphasize enough that the sooner the decision is made to treat the patient and the patient is treated, the better. And if you are going to transfer them for emergency endovascular therapy, then obviously you have the additional urgency of getting the patient moved just as quickly as possible, trying to answer all the questions about whether or not you would, I might request intubation there by the ER staff, or might say we'll just intubate the patient when they get here. All those things would be done in a unique way on the fly while we're evaluating all the options, depending on if it was in the middle of the day or middle of the night. So well, those are the few of the nuances.
Thank you, Dr. Taylor. I really do appreciate you joining us today, and we hope that this will help all of us improve outcomes for stroke patients here in Rutherford County. So thank you very much for joining us.